Hello everyone, thank you for joining us again this February. This is your 76th AeHIN Hour. We are now using GoToWebinar. If you need assistance, please feel free to send us a message through the chat box so we can help you. If you are having difficulties in configuring your connection, please log out from the session and rejoin again. You may also use your smartphones or tablets to join by using the webinar ID 633-363-339. Before we start our webinar, here are a few reminders. For attendees, please be reminded that your microphones are muted throughout the meeting. You can chat your thoughts to us through the chat tab, and for questions, please type them in the Q&A tab. All questions will be answered after the speaker's lecture. We have today with us Professor Xiaoteng Liao. He is a nationally and internationally recognized general practice and informatics practitioner, educator, and researcher as indicated by elected fellowship of the American College of Medical Informatics, peer-reviewed and invited publications and conference presentations, professional committees, and selection panels for competitive grants. Professor Teng's international collaborative research aims to optimize the use of EHR data for patient care, quality improvement and research, and quality of software applications to collect, aggregate, link, analyze, and display data. He has made sustained contributions to primary and integrated care and informatics research with a focus on cross-cultural health and disadvantaged populations. He is engaged in global eHealth and informatics research and capacity building as director of WHO Collaborating Center. He is an associate editor of the International Journal of Medical Informatics and the deputy editor for Journal of Innovations in Health Informatics in Primary Care. His publications contribute to the socio-technical knowledge to understand the cost-effective implementation and evaluation of health information systems and tools. We will now call in our speaker, Professor Teng, for the lecture.
Thank you, Cha. Show my screen. Okay. Can you see my screen?
Yes.
Okay. Good evening, everybody. I'm sure you will all be, I guess, as part of the AeHIN, will be interested in the use of digital information, which is what EHR data is, and digital data from various information systems, and optimizing its use. And particularly for service quality improvement and obviously research and evaluation of healthcare and other interventions. What I'd like to do today is to give you a bit of context and describe a little bit about the activities of the WHO Collaborating Center on eHealth, which is actively working in this, building capacity in this space. And then provide a case study of an electronic practice-based research network in Southwest Sydney, Australia, where we are kind of doing a lot of experiments in assessing and managing data quality of single and multiple EHRs in data repositories to establish, well, to assess its fitness for purpose for, as I've said, for research and quality improvement. And then we'll have questions. So I'll try and give plenty of time for questions and keep the presentation very short. So in terms of the context, the reason why we kind of doing all this eHealth stuff and health information business is so that we can provide good care, good and safe care to our patients and our communities. So I'm sure many of you would have heard of the coronary care model. This is a slightly extended one where it includes clinical and population health outcomes. So if you look at the slide, you have to look at activities in the community, activities in the health system, and activity at the clinical level, where we focus on productive interactions and relationships between the clinician and the active practice team with an activated patient, with an informed patient. And in the same parallel, we talk about a prepared, proactive healthcare provider community and partners in healthcare, having productive interactions and relationships with an activated community. So, and hopefully by doing that, we get good population health outcomes as well as good functional and clinical outcomes. But for this to happen, we need to have a health system that supports good and safe care. So, health system, you have good information systems and good decision support. And when I say good decision support, I don't mean just clinical electronic decision support, but generally decision support in every sense of the word, which can be electronic through systems or through networks and other avenues within a social context and a professional workflow context. Obviously, the delivery system is very important. So we're talking about integrated care and so on, coordinated care, managed care and so on, and how the system needs to support that. And we need to develop self-management and personal skills of the citizen and the patient. And that's where they interact, and that's, I guess, the primary purpose of the health system. Obviously, in the community, you need to have good community action by the local communities. You've got to have a supportive and accountable environment, and you've got to have good, healthy, and good public policy, and good systems in place to support the health system and the community and the individuals and their families to interact in an informed way with the healthcare team and the healthcare system. So that's, I guess, the context and I guess the reason why we are doing what we're doing. So everything that we do, I guess, in my case anyway, in the description of some of the projects that will follow this slide is based on that big context. The other context is the Sustainable Development Goals, which has replaced the Millennium Development Goals. And that's, I guess, where the WHO Collaborating Center objectives come into play as part of the overall implementation of the elements of the chronic care model. So there's, I'm sure all of you are very familiar with it. No poverty, no hunger, good health, quality education, and so on and so forth. So I guess from the eHealth point of view, we'll focus on good health, industry, innovation, and the infrastructure, and I guess the social technical aspects, which includes partnerships to achieve those goals. Obviously, the others are very important, but I guess the focus will be on 3, 9, and 17. So I guess the partnership is very important, and I guess the attitude we need to take is also very important. This is a very interesting quote from the people who developed the United Nations, which is that half the people living in extreme poverty in 1990 are not anymore. All right, it is to have to show that this is not just an idealistic dream, the realization of the Sustainable Development Goals. With the Millennium Goals, Development Goals, there was some progress, and the whole process of the Sustainable Development Goals adds in the dimension of sustainable and take the new goals even further to address the root causes of poverty. So the thing is optimism. It's not just an idealistic dream. Second, obviously, good health. Prevention, I guess, is the key and should be the focus. And obviously, in this day and age, management of chronic disease is very important, or non-communicable diseases. But at every stage of the care process or the therapeutic process, there's got to be an element of prevention, either primary, secondary, or tertiary prevention. Obviously, the technology and infrastructure and innovation. So this is Bill Gates. Never been before in history has innovation offered promise of so much to so many in so short a time. So that's the key concept is digital speed. We have, and to come back to the topic of tonight, we have much greater access to information that we've never had before. The question is, how good is the information and what use can we make of it? All right, so I guess that's the kind of contextual background, and I'll tell you a little bit about the WHO Collaborating Center. This is the second regional forum held in November in Manila at the WHO Western Pacific region in Manila. So this is a lot of them. There are a lot of collaborating centers in the Western Pacific region, including in the Western Pacific, and there's about 100 plus. And they all range from a whole bunch of health things, and there's one eHealth thing, collaborating center that is based in Australia, in New South Wales, and I'm the director of that. But there's a couple of other terminology and more specific biomedical kind of informatics type collaborating centers based in China. So, but there is a big family of people covering the whole range of health and technology, or information technology and informatics across the Western Pacific and the Sierra, which is, I guess, the sphere of influence or the regions that AeHIN is involved with. Our specific terms of reference is essentially to support and grow evidence-based assessment and evaluation of eHealth with a focus on mHealth for age and care of chronic diseases. And the guiding framework is social. Focused, so that it is more health as opposed to disease focused. And then obviously directly working with the citizens themselves or the patients and their carers and their families to assess their readiness to take up mHealth, eHealth tools, and then engage them, because you have to make sure that the tools are usable and easy to use and therefore sustainable. And the fourth dimension is essentially the first term of reference, making sure that we got rigorous measurements and evaluation of the processes and impacts of eHealth across the Sustainable Development Goals for individuals, family, and the community, and in the facility, the hospital or the general practice or the community health center, in the district, in the region or the state, and in the nation. So that's the kind of guiding framework that kind of contextualizes what we try to do within our own research as a part of the WHO Collaborating Center. So some of the projects and I will talk about the first one as the electronic practice-based research network where we are developing and validating tools to extract, link, share, and use digital data. And then there's a number of activities with various partners. We have a partnership with the Cooperative Research Center in spatial information, where we're trying to work on spatiotemporal systems for public health, for instance, disaster management, and clinical care, for instance, integrated care, and understanding how people use services from a spatial and temporal point of view. Obviously, we've been working with partners on the use of various eHealth and mHealth and telehealth tools and services for elders and vulnerable groups. So for instance, there's a diabetes online project where we work with primary care centers and community health centers and general practices to engage the GP and the nurses in using online tools with the patient to who are screened, especially recruited because they score lowly on the health literacy scale, to work on how to improve the management of diabetes using shared online tool. So those are some of the approaches that we take, which is citizen-focused and involving an engagement between the provider and the receiver of the care. Citizen engagement is essentially not just public participation. We actually work closely with the Yunus social business centers, and we have established a Yunus social business health hub at the University of New South Wales, which is exploring aspects of eHealth, digital health, and taking a social business approach to making those kind of projects sustainable over the long run, with a focus on addressing poverty as is characteristic of all Yunus social business centers. And then obviously measurement and sociotechnical evaluation, and we have kind of been working on the safety, usability, and cost effectiveness of the eHealth tools that we either been asked to evaluate or have developed and will be evaluated and have evaluated and validated, and so on and so forth. So that's kind of the context in the broad sense of the current care model and the sustainable development goals, and specifically how the WHO Collaborating Center fits into this, and how it fits in with AeHIN in the Western Pacific and the Southeast Asian regions of the WHO. So with that in mind and in the background, let me just get down to some nitty-gritty and give you a case study of using what we've been doing in Southwest Sydney. Obviously, if you want to talk about maximizing or optimizing the use of EHR data, you're not talking about one EHR or one health information system or one health information technology tool. We're talking about networks. We're talking about a number of them, lots of them, multiple. So that's what an electronic practice-based research network is, right? And this is our logo. Okay, it's an electronic practice-based, and it is based in Southwest Sydney. Now, you might ask me, where is Southwest Sydney? So that's Australia. I'm sure you're familiar with that. And this is Southwest Sydney. Okay, here, the red dot. That's Sydney, and Sydney is at the southeastern coast of Australia. So that's where southwestern Sydney is. It's got about 1 million population. It is the most multicultural local government area in Australia. This is also the poorest local government area in Australia, with high prevalences of disease, both infectious and non-infectious diseases. The organizations in there are the local health district, that's what LHD stands for, and so that that region of about 1 million people are served by 4 hospitals and a bunch of primary and community health services within the auspices of the local health district. And within this district, Southwest Sydney, there's also the PHN, which is the Primary Health Network. It supports about 500 general practices, which is the total number of general practices in that region, and which consists of about 1,200 to, I think, slightly more now, GPs, general practitioners. So that's kind of the health service that's available in this region, and which has about a million people from about 100 different cultures that's migrated or sought refugee status in Australia, and is probably the poorest local government area in Australia. So that's the geographical context that we're talking about in terms of the work that we're doing. So the EPBR, the Electronic Practice-Based Research Network, in essence, is a health information partnership, because we extract data, put it into a data repository, and there are partners who own the data. Okay, so this is Southwest Sydney in terms of a Google type map, and this is one of the hospitals, and called Fairfield Hospital, where the general practice unit is, and we have integrated primary care center there. And this is Wallandale. It is another region, a rural region in the Southwest Sydney. It has got a small hospital, about 100 beds, whereas this hospital is about 300 beds. And there's a big hospital here. One of the 4 hospitals has got about 1,000 beds, and the others, and another kind of medium-sized hospital, about 500 beds. So this is a rural area, and there's another area here that we're extracting data from. So we have 17 practices. We extracting data from 1 hospital, 1 diabetes clinic, and to allow us to do this kind of, I guess, formative research where we developing and testing tools to use the data, and then doing some evaluation using some clinical use cases. So we do monthly extractions, and there's about 170 individual patients, and we define active patients as patients who have actually attended the health service 3 times in the last 2 years. So there is this, in this rural region, we use a telehealth model. In this semi-rural region, we have a co-located public-private partnership integrated primary care clinic, and there's a publicly funded integrated primary care clinic in this region. So that's kind of the geography of the place where we're doing this work with the EPBRX. So this is the geography of the case study, and the amount of patients, services, and the amount of patients involved. So the methodology, we have general practices, we have integrated primary care centers, community health centers, and so on, working at the primary care level. We got at the secondary care level, and as I mentioned previously, this is supported by both the primary health network and the community health centers are supported by the local health districts. These are purely local health districts, and there's a diabetes clinic based at the hospital, so because we're using diabetes as a use case. And the hospital where we get data, extract data on emergency department visits and hospital admissions. So we call this whole thing an integrated health neighborhood. All right, so there's an active referral system network across this in the geographical space called an integrated health neighborhood, or a number of neighborhoods. So from this, we actually, from the information systems of these different services, primary and secondary care, before we extract the data, we pseudonymize the data. So any data that leaves the unit, the clinical service, cannot be identified. It is pseudonymized. It is de-identified. And then when we have pseudonymized the data, and that's a process where we kind of represent the patient with a hash pseudonym. And then we extract the data into a firewall protected database where we do record linkage. It is a SQL strength database. And so it sits within its own firewall, and we do linkage. And after linkage, it goes into another server where we actually work with this database of linked pseudonymized individuals, virtual individuals, to do research using this big data. Obviously, when I mentioned the fact that we had about 170,000 patients, I mean, that is scalable. So we're working on scaling it up gradually, neighborhood by neighborhood. So that's the kind of basic methodology. But the key kind of thing is that we want to improve the data quality, and we provide feedback to all the services in the neighborhood. So this is DQ, stands for data quality, and then we provide feedback to the management or the administration of the health services, as well as the clinicians providing the services. So there's a kind of a cycle here where we iteratively improve the quality of data, as well as generate research questions based on the feedback to the service units. So it is a virtuous cycle of improving data quality and generating research questions from ground up. So that's the methodology and the tools that we use. And most of it has been validated and it's all been published. And if you want those references, I'm more than happy to share them with you. So these are some of the lessons we've learned from this case study. First, before we started the network, we did a community analysis, needs assessment, to find out how the extent of data sharing. And this partly is the reason why we developed the network, so that we can improve data sharing and sharing of good quality data. So we found that primary and secondary care clinicians fail to share data beyond the traditional referral letters and discharge summaries. And we published that in the Journal of Biomedical Informatics, and also a number of other journals, which I won't, it's kind of no space to put in here, of the needs analysis, as well as some of the things that we've tried, intervention and tools we've tried. This particular publication concerns formal ontologies to improve the accuracy of diabetes disease registers. So there were some challenges, obviously. The quality of the data issue is a big issue. Privacy and security is not really a big issue, but it's of great concern to the participants and the patients, but more the participants, the professional participants. And then obviously standards and the governance of the quality, the privacy, and the standards. And obviously the capacity, and especially from a socio-technical sense, all right, needs to be improved. It's got a long way to go, but I think we're making good progress. And I imagine it will be very similar across the world. And when I talk about socio-technical, I'm talking about both, not just the hardware and the software, but the people and the networks that we have. So that's one lesson we've learned, that we've got a long way to go, but I think we've got some tools and some methodologies to address that. The existing tools were also evaluated as part of the process of setting up the network. So we found that as we evaluated it, and we published on some of the tools we evaluated, to be inconsistent. So for instance, we look at data extraction from electronic health record. So there was a number of tools being used by a number of practices of services. They are already in place. And we use a particular tool called Granite. So we actually did a comparison, an independent comparison of 3 tools. Okay, and we found that they are inconsistent, because we knew that our tool, and we were very clear where the data was coming from, and we used a standard data set, we could actually benchmark it. So we found that the existing tools were not consistent, and as a result, we recommended the government and the industry that those tools must be validated robustly within a transparent data and clinical governance framework. And I think they're starting to work with us on that. So like there are some big projects going on in Australia that we are part of, advising them on how to adhere to make sure that the tools and the data are fit for purpose. So that's the other lesson that we learned. Don't trust the tools until you have it tested and validated. Obviously, as a result of that, data quality is an issue. We looked at both primary care and hospital systems, especially the emergency department, and we published that in Emergency Medicine Australia in a number of places, just highlighting the fact that there's significant data quality problems, and that it may be useful for quality improvement work, but it's definitely not useful for clinical decision support systems, especially if we do it fully automated. So we worked on the data, and as I mentioned before, there's a feedback loop in the system that we set up. So we create structured data quality reports where we look at the completeness, the plausibility, and the kind of the data in terms of normal ranges and the actual terms that were used, and obviously the consistency with the coding system. In this case, in Australia, we're using SNOMED City as the benchmark, but obviously ICD-10 is the kind of a managerial benchmark that we also use. So we found that by providing feedback through structured data quality reports, we actually improved data quality. This was also published in the International Journal of Medical Informatics. And interestingly, the data improvement was based on 6 monthly feedback. And we got it up to, I think, a quality that we can use for research, providing we understand that it's not complete, but we definitely haven't met the benchmarks for accreditation in terms of the completeness of the data. And so the other activity that we're really interested in is we have actually developed with colleagues in the United States with the EDM forum community to develop a comprehensive data quality assessment framework with a standard terminology for data quality of electronic health record data for secondary use. So it addresses data verification and validation across space and time. So using the completeness and the plausibility and the consistency dimensions of data quality. So that's the other lesson that we learned, that we need to have systems in place to assess and manage data quality, but we also need to do it internationally, because I think at the end of the day, if we're going to make use of multiple EHRs, the inconsistencies within a country or within a state is just the same as across nations. So we might as well do it, and we got a project currently going on now where we're working with colleagues in USA and UK to harmonize our data models as well as the vocabulary. So that's kind of the other key lesson that we've learned, all right? Consistency and data quality, and in this case, interoperability of the data. And I kind of sometimes separate interoperability from data quality, but I think it is interoperability is an integral part of data quality. And because we're also linking data, and we use probabilistic record linkage to create a pseudonym as part of the process that I showed you in the methodology. And we actually tested the accuracy and value of this record linkage methodology and tool across a number of EHRs. And we found that it was quite reliable through validation using the statistical techniques, as well as actually re-identifying a random subset at the practices. Part of the pseudonym creation is that the pseudonym is created at the service unit, in the service or the general practice unit, and it can't be changed once it leaves the unit. The only way it can be re-identified is to go back to the service unit where the governance is local and relevant to the patient and the practitioner. That's the only place where you can re-identify the patient. So there was some obviously, like when we deal with a lot of patients, there were some problems where we could cannot handle. There are small numbers, but one of the biggest problems with that small numbers, with less than 1% or less than 0.1%, is sound-alike names. For instance, I mentioned that the Southwest Sydney is very multicultural, and we got the highest proportion is Arabic people, Middle Eastern refugees, and Vietnamese. Okay, so the names, especially the surnames, sound very much alike, and that presents a problem. But we know that's a problem, so we take extra care with those particular cultural groups. So we know the linkage is reliable, but we need to be aware with, especially with sound-alike names. We also tested an algorithm to find cases of type 2 diabetes, and we developed the algorithm to phenotype the database into type 2 diabetes with a number of cases and we validated it and published it, and it's been peer-reviewed in a journal. So what we did was actually had funding from one of our insurance companies, the HCF, and where we actually linked data from general practices, diabetes clinic, and the local hospital admissions data to, I guess, develop a predictive model for admission for people with type 2 diabetes based on that record linkage and the linked data. So by having that data from general practices and the outpatient clinic and the local hospital, we were able to divide the groups into comparator, in general practice that is, who have been admitted, who have not been admitted. And we found that when we compared those two groups, that when they had more general practice and clinic visits, diabetes clinic visits, they actually protect them for admission. So they was less likely to be admitted. But once they actually start to develop renal complications and so on, and they tend to predispose to admission. But there are other factors that I'm not mentioning here, but things like if they're smokers, they're more likely to be admitted, and some of those clinically kind of intuitive risk factors were also confirmed. So, but it is a really incredible, powerful tool to do this kind of research in using like EHR data. So we found that you can have reasonably, acceptably accurate algorithms, and you can do, by having those algorithms, you can actually start to combine it with record linkage and do research that health services and translational research. But obviously, once we actually start to incorporate data from our genomic databases and so on, we can actually provide more personalized calculations and algorithms to refine this risk stratification even in more details. In fact, we're doing a project right now. We're going to start a project this year, which has been funded by the National Health and Medical Research Council in partnership with Stanford and Oxford, to actually see how big databases can help us, big clinical databases can help us practice personalized medicine through the green button concept, where you kind of look at the patient, look at the demographic data and their presenting complaints on, and then you query the database in real time in terms of patients like this particular patient. So you can actually say, this patient sitting in front of me, and can tell them that I've got maybe 50 patients like you presenting with this problem, and this is what happened to them over the next 12 months, 1 year, 2 years, 5 years, and so on. So this is very powerful kind of use of EHR data to personalize the management of patients. So, so those are some of the more technical issues. But obviously, there are other social technical issues that we're interested in. And we also, because with our international collaborators, we actually ran a couple of workshops with the National Association of Primary Care Research, North American Primary Care Research Group, and also at the MedInfo with international collaborators and other people interested in this area, and ran workshops to try to define what are the barriers and what are the challenges of trying to use EHR data for quality improvement and for research. So these are some of the issues that they describe. So we need to be aware of as well, wherever we are. Interoperability, big issue, and I think I mentioned that. Proprietary software and transparency and lack of transparency. All right, so this commercial incompetence and big black boxes are a real issue, not just in Australia, but everywhere. And we need to understand that. We need to get vendors to understand that there's a need for transparent validation and evaluation of the accuracy and the fitness for purpose of your tools. Obviously, the business model is important, and sustainability. And I guess to some extent, the business model is, especially with all the work that we've been trying to focus on through WHO and in developing countries, we think there is a huge future in the social business concept, that it is a not-for-profit, but it is using a business approach with the broader aim of addressing poverty and improving the community engagement and improving their education and so on with the 17 development goals. That's probably the way that we need to focus our energies in terms of sustainability, that it becomes community development, it becomes a community development model using business approaches. So that's kind of things that we're working with the Yunus Center, Social Business Center about. Obviously, the other thing is from both the clinical and population health perspective, there are multiple ethical issues and challenges that needs to have a kind of coordinated and integrated approach. So with international colleagues, we have actually done a Delphi study from experts all over the world to work out a framework to help us not put barriers in place, but to meaningfully govern how we access data in medical record systems and health information systems to do ethical and secure and confidential research that protects the identities and the privacy of patients and providers. So that's kind of ongoing work. And I think, obviously, like with any governance and change management issues, it is highly contextual. So, so there's a scope for individual countries, or whatever, not just countries, but also at local levels, to actually start to develop governance and other systems to ensure that we ethically and meaningfully use our digital data. So that's something that's happening that we want to build on, and that's the other basis of what we talk about, the integrated health neighborhood. We see the integrated health neighborhood is like how granular, at what level. So is it, in this case, in Australia, we look at it as the local health district level, where there is a number of hospitals, and it's small enough to be kind of cognizant of the consumer and the citizens' needs, but also small enough to be cognizant of the healthcare providers' needs, to protect the quality and the safety of their involvement in using our digital data meaningfully, and to collect it in a way that can be meaningfully used. So finally, one of the other concepts challenge that was brought up by the international group has been the cognitive load on patients and clinicians from managing multi-morbidity. So, there's a whole lot of, the chronic care model is complex as it is, but when you start to build in multiple morbidity and so on, it gets even more complex, especially at the interaction and relationships level, and understanding the evidence and building the evidence as we go along. So there is an increasing cognitive load that we need to be very cognizant of to manage and to make sure that it doesn't kind of fall flat on our faces. So there is international consensus on some of these issues. Oh, well, this list of issues is a consensus list from our international workshops. So some of the learnings to summarize. If we're talking about eHealth and eHealth tools and integrated primary care, we require integrated health data. See, the United Nations, or WHO, is very focused on integrated care integrated care by integrating primary care into various chronic disease management, including mental health. So we're talking about integration all the time. So we need integrated health data and systems with local customizations and a socio-technical approach to implementation. And it's probably best done at the integrated health neighborhood level. We try to make a case, we've published on it, and make a case for use of integrated health neighborhoods, like I've described, as the unit of governance as well as unit of research. The second other thing that we kind of crystallizing and developing our thoughts on this are the governance, the clinical and managerial and evaluation matters must be integrated and addressed through virtuous alliances. And by that I mean health services or the health system, the business community who are doing health-related matters, especially e-health matters, and academia and the people who will be ensuring that the interventions and tools are robustly evaluated and validated, and that the data is fit for purpose. The business model must be sustainable, and this is very big in the Sustainable Development Goals. It must be fair and equitable, and this includes industry engagement. So equity and social engagement is key to make the business model sustainable. And evaluation must consider all these factors. So we need to, and therefore the evaluation must be kind of using EHR data, which is longitudinal and of questionable quality but improving, and building the research methodology using both quantitative and qualitative methods around the use of EHR data. So I guess that's probably all I want to say now, and I'm open for questions.
Yes, thank you for that lecture, Professor Teng. For those with questions, please type your questions in the questions box. If you cannot find it, please type your questions in the chat box. So for the first question, here is a question from Dr. Anand. It reads, how did you come up with your definition of active patients to include patients who have followed up thrice in 2 years? And do you have problems with patient duplication in your area?
That's a very good question, whoever that is. The definition of an active patient is something that I guess the UK and the Australian systems have kind of developed, and it's basically based in primary care and general practice, where they say there's no point because we build up a patient base all the time. So like I might have about 20,000 or so patients on my list, on my database, but only some of them have been in the last 2 years, all right, or have been in recently, and I don't see them all that often, and some of them might have moved away and so on. So when we do our analysis, we focus on the active population, and we found that the definition of 3 visits in the last 2 years is probably the best kind of a representation of an active patient. There is no empirical evidence to say that that is the best definition. I mean, there are others, but that's probably the easiest to do to automate and without going to kind of more qualitative approaches like identifying the regular patients and so on. So I think this is probably a good epidemiological tool to understand health services and how people use the services of the individual services. In terms of that's the answer I can give, because that's how it is been adopted. In terms of duplication, yes. When you talk about multiple EHRs, especially when you talk about a neighborhood, there will be people traveling around different practices. Sorry, I'm just going to make sure the question was about duplication, right? Char? Oh, okay.
Yes.
So there is up to about 5%, and some places where, and we have actually worked out the space, this kind of distance between practices, and distance between practices and the referral hospital or the hospital that provides the acute services, and that it is consistent with distance. But there is up to about 5 to 6% sharing of patients among general practices and primary care clinics, because of usually people go on leave and because of access issues, I guess, basically. So I hope that answers your question.
Right. Yes. This question is from Dr. Anand also. Are there other such systems in Australia? Is this integrated system something you are looking at scaling to the rest of Australia?
We're hoping to scale the neighborhood concept to the rest of Australia. So what we're doing now is scaling up. It doesn't matter what the system is, right? Right now we have, in Australia, we have about 6 major systems in primary care and about 3 kind of major hospital-based systems. And those are the Cerner's and the Epics of the world. So this is a middle layer approach to data. So, and that's both a strength and a weakness. Like for instance, it took us about 6 months to get data from the big hospital system. It didn't take us any amount of time to get data from general practices on who sign up to do this project. So there's a implementation issue when you talk about the size of the system and the complexity of the organization. But so what we're doing is actually integrating the information by extracting the information out into a common data model and working with that to link up at that level, at the middle layer, with other systems from both primary and secondary care. So if you call that the integration system, that's the approach, the middle layer approach, middle layer application approach. Most, like for instance, a lot of the hospital-based systems have got what they call an integration engine, because within the hospital system of, in this case, the local health district system, there are a number of different disparate systems, so they need to try to integrate that as well. So the data model is not common across all of those systems, and the data terminology and vocabulary is also not consistent. So that's what some of the problems that we have to deal with, and in the hospitals, and that's a harder nut to crack for someone like for academics, because there are more vested interests there compared to general practice, where it's only one vested interest, and that's the general practice, whether it's a big group practice or not. So what we want to scale up is the approach, the methodology, and the neighborhood concept. Now, in a rural setting, the neighborhood might be different from a large metropolitan setting. So we might have just one hospital as the neighborhood and the surrounding services as the neighborhood. Or we might have a local health district as the neighborhood, which is a number of hospitals. It all depends. But the beauty of this approach is that we deal with individual health information systems, so we can actually configure it any way we like in terms of the neighborhood, depending on the research questions.
Yes, thank you, Professor Shao. Yes?
No, keep going. I think that's...
All right. So for the next question, this is from Dr. Chaka. It reads, thank you very much for the impressive presentation. I guess ontology is the heart of your work. As far as I know, only SNOMED CT is not sufficient for this level of work. So could you please explain a little bit in detail about ontology developed or used?
Okay. Ontology, I guess, is really a formal modeling exercise in the software. So it is kind of, usually we talk about models. Models are more abstracted and less kind of real world. We use ontologies because it's kind of more real world. And what we like to do is actually, if there are already ontologies out there, and there are lots of little ontologies being developed, and there's a large repository of it maintained by in the States, and also some other kind of open EHR have got a number of models that are very like ontologies. So there are libraries of ontologies that you can use, okay? But essentially, you still need to have some local specializations, especially in terms of the vocabulary. So like SNOMED is one ontology, right, that people have used, and different aspects of it. So I guess the idea behind using ontologies is that kind of formalism. But the clinical basis or the managerial basis on developing the ontology and getting the final ontology before you actually translate that into a software is the most important part, in my opinion. Okay, because you need to be able to be flexible enough to cater, to describe what's happening in your locality, but also flexible enough to predict what's going to happen based on the data you have in the next year, whether the patient, say for instance, whether the patient might get admitted or not. So I think that's the challenge of ontologies. You probably, I don't know whether the question, for the technical person, especially in this semantic methods that we use nowadays, and I don't claim to be an expert on ontologies, but the beauty of it is that you focus on the real life situation, the use case, and then you develop the ontology, but develop it so that it is actually flexible enough to allow you to describe and predict.
All right, thank you, Professor Shao. We're down to our last question. It's from Dr. Beastie. Thank you, Professor Shao, for your presentation. Could you please go further in main factors or dimensions of data quality you refer to? And which is the role of medical doctors in using WHO international classifications in the AHR?
Okay, if I understand the question correctly, international classification, I think a lot of the hospital systems use ICD-9 or 10. In Australia, we mostly ICD-10, but I think the state's different. SNOMED is more of a clinical thing, and it's still very being rolled out very patchily in Australia. The emergency department have started using it, and which is why we kind of use them as the test use cases, because they're kind of a little bit more leading edge. But it's still not well implemented or rolled out in Australia. And there's a whole bunch of reasons for it, and that's some of the reasons that we talked about when we talk about the international consensus on some of the challenges. And so it is a difficult question to answer, because you really have to kind of understand how to use SNOMED, and then you got to train people to actually implement it well, and then you actually implement it in the system. But at the same time, you need to train people to actually know how to use it in the system, down to the clinician, down to the actual people who are entering the data, and whether as a information manager or as a clinician collecting data during the clinical workflow. And the other bit with SNOMED and some of the ontologies, and I think that's probably one of its weaknesses, is that it's probably trying to run before it can walk. If just using the SNOMED as a terminology and with some ontological relationships, is probably the easiest starting point. To try to talk about, say, using it as a compositional kind of system, where you can actually create constructs like left leg, or fracture of the left leg, or fracture of the left femur, which is comminuted and so on. So it allows you to build that up. ICD is a little bit easier. So if we actually start to, I'm not sure how, but if we get our collective brains together, we can actually start to work out how best to start to implement the ICD-10 or ICD-9. I mean, in a way that we can take the step into more flexible terminology that allows you to build good ontological approaches to very specific local clinical or managerial issues that needs some evaluation or some research, and as an implementation to address those issues using your health information system. I might leave it at that, because the further you go to it, the more you realize that it's going to be even harder if you don't start to take a step back and bring people with you all the time. But I'm happy to provide the references to, like for instance, some of the ontology work that we've done.
All right, so I guess that's the last question. Thank you for the lecture, Professor Tang, and also to our participants who actively joined our webinar. May we also invite everyone to join us next Wednesday, February 15 at 8 p.m. Manila time. We will be having a webinar on RHIS tools. Again, thank you, Professor Chow. Thank you, everyone. Have a good night.
Thank you. Thank you for listening.